Our next speaker is Dr. Sadana, our Medical Director, Critical Care Services. Thank you, Dr. Sadana.
Thank you. Morning, everyone. Thank you for being present here on a Saturday morning where you could have been doing a lot of other things, but we do have some good information for all of you and also how we are performing in our institution. Dr. Papazai has already addressed that. I'll be talking about pulmonary issues and respiratory medicine in the neuro ICU. Interestingly, the neuro ICU, besides have actually neuro problems, there is also the issue of managing patients who they get constantly associated with pulmonary issues. I have no financial disclosures. Our objectives are in this short period, which I'm going to talk about, you can't address all the other issues, but I'll just address most of the common things which we do see and come across and how to manage them. Talk about airway management and also when should we do tracheostomy in these cases, mechanical ventilation and hemodynamic monitoring, including non-invasive hemodynamic monitoring as well as also therapy, non-invasive ventilation as well. And a few of the pulmonary conditions which we commonly come across, which is acute respiratory distress syndrome and acute pulmonary embolism, COPD. They are not on the same order which I was showing on the slide. They will be a little different in the order, but we'll start. Start off with a scenario, which is a 36-year-old male who has history of myasthenia gravis. He's admitted to the neuro ICU with respiratory distress and fever. On exam, he's got weakness of neck, flexures and extensors and tachypnea in his hand, but is handling secretions pretty well. This got probably precipitated by a pneumonia, looks like. He's got a left lower lobe opacity in his chest x-ray. Arterial blood gases are acceptable, but they are on oxygen at 6 liters nasal cannula. He's not hypercapnic yet, just slightly elevation of the CO2. And the question is, what should we do next, invasive ventilation versus non-invasive ventilation? Or are we going to intubate the patient? As in the next hour or two, his workup breathing increases and his arterial blood gases show that he's hypercapnic now, and with a non-rebreathing mask, his PO2 is only 86. So our indications of intubation in these scenarios is predominantly hypoxia acutely, which has progressed, and workup breathing. Watching the patient is more important than just sometimes saying that, oh, okay, this patient is hypoxic and we need to intubate. Now, some of them may be chronically hypoxic, but obviously in this scenario, it was an acute event, and acutely hypercarbia has progressed. So increased metabolic demands also, these are other conditions, including shock, where the patient also is hemodynamically unstable, can also lead to requirement of intubation, where you want to give the patient rest and reduce the work of breathing. Other conditions, of course, which we commonly notice is inability to protect the airway or upper airway obstruction may be there. Low GCS, commonly below 8, it's commonly that the patient will require mechanical ventilatory support. An acute stroke where sensorium has impaired severely and bulbar weakness, especially in these cases with neuromuscular diseases, there may be increased bulbar weakness, or a brainstem stroke would also lead to it. Upper airway edema is another condition, and trauma, and of course spinal cord injury. So all these conditions can progress besides others that the patient requires mechanical ventilatory support. One more thing to watch when we are going to intubate a patient is to assess that if the patient is going to be a difficult management or difficult intubation. And here are some of the criteria which we commonly can be used to come. It's a lemon laws. It says look, evaluate, look at the melon patty and obstruction of the part in the throat and how's the neck mobility. So simply one can examine and see what's the melon patty. Number one is where you look at the throat open if it's possible. Sometimes in emergency you may not have the chance, but you can basically very simply look at the melon patty scoring or classing. And also there is 332 measurement that if you can put three fingers in the mouth and if there is a 3 fingers between the mental and the thyroid cartilage or the two fingers at the hyoid and the base of the throat, if that could be, if these are okay, but these are arbitrary more or less a lot of times. But these definitely help you to come to a conclusion that if this is going to be a difficult intubation or not. Uh, Another thing is extubation. Once patient has been intubated and it's time to get the patient off the mechanical ventilator, extubation and tracheostomy considerations. I'll give a few words on these. There's limited data on in neurological patient of the specific weaning trials in neurologic of extubation. The one of the most important thing which we do not only on neuro patient and non-neuro patient is rapid shallow breathing index, and which is a respiratory rate versus tidal volume ratio. And if it is below 105, mostly the success of extubation in these cases would be about 90% or more. This has been tried over time and has been proven to be very successful. Uh, Though there are variations at times, there are individuals who don't fall into this criteria, but most patients will. Patients with Glasgow Coma score of less than 8 can be extubated if they have an intact cough and gag and spontaneous respiratory drive, which is good in these cases. So it's not always that you cannot extubate patients who don't have a below 8 GCS. Another point about tracheostomy, in mostly we'll do a tracheostomy, and it has varied over the country that we have seen tracheostomies being done. In general cases, anywhere from 7 to 12 to 14 days or so. In neuro patients, if the patient is going to be on a prolonged mechanical ventilatory support, we recommend that early tracheostomy be done. And most major centers are now doing it anywhere on the 4th to 5th day. These okay. These are some of the bedside pulmonary function tests could be done, especially in the neuro ICU, to see these will give an indication whether the patient requires further mechanical ventilatory support or not. They're kind of hard to do, okay, and most of the applications would be in neuromuscular diseases, mainly like Guillain-Barré or myasthenia gravis. And out of the three which I have shown here, the forced vital capacity is one of the most important ones. If the forced vital capacity is below 20 ml per kg of body weight, a good chance that it will progress to respiratory failure. And if it is at 12 to 15 ml per kg of body weight, definitely intubation is required in these cases. The others are negative inspiratory force, and if mostly this is again All of these are indicative of diaphragmatic and respiratory muscle function and is declining. Mechanical ventilator will be required or ventilatory support of some kind. The maximal expiratory pressure also could be done, but these are kind of, like I mentioned, are not easy to do uh, in the ICU, and especially on a sick patient. So FVC is probably the most common one which is used and is the most reliable one and can help out. Here are some graphics which we see in patients who have neuro injury, and these are graphics which can be seen in the ICU in patients who, when you're monitoring them, how their respiratory patterns are. Now, once the patient is intubated, you may not see this pattern because the ventilator has taken over and pre-intubation many a times, or if you put the patient on spontaneous breathing on the ventilator and are deciding what we do next is the patient can come off if a breathing trial is being given, spontaneous breathing trial is being given to that patient. The one of the most common ones is Cheyne-Stokes respiration. Usually this is seen in bilateral cortical injury. This is also seen in other scenarios with patients who have underlying cardiac disease or poor cardiac function. But in a neuro ICU, this is the common uh, pattern seen with cortical injury or cortical trauma or strokes. The next one is central hyperventilation, and it's uh, low midbrain or upper pons injury, and this will be the pattern which is seen. And apneustic breathing, which is usually and during the injury of the middle pons, where you see a sudden inspiration followed by apneic episodes. So the other one is cluster breathing, which is a lower pons injury, which is rapid inspirations followed by, again, apneic episodes. And then ataxic breathing, where is a brainstem injury, especially in the medulla. They are pathognomonic of a poor prognosis, especially most of them, and one can get an idea in the intensive care that where the injury is, that's basically where this evidence comes around. Monitoring, and you are definitely going to be monitoring pulse oximetry, high blood pressure, etc., and also end-tidal CO2. End-tidal CO2 does help to decrease early on getting an idea of what's going on with the patient if suddenly the pattern and the graphics do change. Elevated end-tidal CO2 is usually seen where there's a decrease in respiratory rate or decrease in tidal volume, and of course metabolic demand increases, especially with fever or patient going into a state of shock. While low end-tidal CO2 may be increased where the respiratory rate or increased tidal volume or respiratory rate increases, metabolic acidosis develop, and also will be seen with acute events like acute pulmonary embolism. And that would be a good indication that there's something gone wrong and suddenly the end-tidal CO2 has dropped significantly. Some of the graphics are described here that what other patterns could be seen in the ICU when you're monitoring, and the graphics change of end-tidal CO2 monitoring, which is sometimes helpful very much. Also, it could be noticed in scenarios where the endotracheal tube gets blocked and there is not adequate ventilation going on, and that will be evident in a drop in end-tidal CO2. Uh, as we are talking about mechanical ventilation and also intubation, and what are the drugs which we'll use to facilitate for intubation. These are just a few of the drugs I've put here, but there are others mostly. Most important thing is that when we intubate an individual to be placed on mechanical ventilation, must use not only just sedation but also analgesia. The other important thing is because these are neuro injured patients who have definitely a lot of them may have increased ICP or intracranial pressure would be quite elevated. So we have to use drugs to be careful that we don't increase or decrease the intracranial pressure. One of these analgesic drugs commonly used is fentanyl. You want to use this short-acting uh, analgesic medication, and of course, a amnestic drug should be used. I would prefer most of them that they use fentanyl along with midazolam, and also uh, a good one to use is propofol. Propofol does reduce intracranial pressure, but the problem again with propofol can cause hypotension. All the others have their own benefits and pros and cons, which are present on this slide. And then the neuromuscular paralytic agents are also used along with it. The other controversy has been that should we use lidocaine, okay, or not. Currently, we are recommending the use of lidocaine, though some studies have shown it doesn't make a difference. But benefit of using lidocaine is there is a laryngeal cerebral reflex indirectly, which raises once during the process of intubation, which raises the intracranial pressure, especially on a brain injured individual. You'd like to make sure that you do not cause further harm, right, or any further injury to the brain, and to raise interest. So lidocaine on a small dose, 25 to 50 milligram IV push, if it's not contraindicated or patient is not allergic to it, should be given prior to. The SSRI kits do have lidocaine in them. These are some of the adjunct devices to use for intubation. The best one I would say is the physician should be using, or the clinician, whoever is intubating, should use with the best results could be with a video laryngoscope. Two types which Pomona Valley carries. One is in the AMBU and the other is the glide scope. I do recommend that the intubation should be done in one shot. Every time, as more attempts are made, not only raises intracranial pressure and local airway injury starts to happen. So the individual who is intubating should be an expert, should use it at one time, and make sure we are successful with it. The other adjunct devices like LMA or bougies, etc., those are kind of at where a situation fails and are being used. It's best that call for help for somebody who has the expertise if the success is not there for intubation. And prior to that, of course, preparation is very important prior to the intubation, that the patient to be positioned appropriately, be well oxygenated, okay, and prior to the attempt to intubate. A little bit about the ventilator settings and ventilator basics. These are some of the modes most commonly used on mechanical ventilator supports once the patient has been intubated. Uh, it's control volume versus pressure ventilation, and assist control, which is and support. There are three usually ways which we deliver gas, okay, by volume and by pressure. And the patient triggers the ventilator. The trigger may be through flow, which is being delivered through by the ventilator and the patient triggers it, or by pressure, what the patient uses negative pressure to start. If the patient is a coma scale of 3, none of this would, the flow nor the pressure will work, but the ventilator will continue to, by its timed, whatever has been set, will trigger the breath. The target, of course, is how gas is going to be delivered via flow or pressure, and then the cycling mechanism, which will terminate the breath. This could be as a pressure breath or a volume based or flow rate. Now, most our newer ventilators really, we have found that there's a combination of the mode of pressure as well as also of volume, and that's being used nowadays, what we call pressure regulated volume control ventilation. So we take the best benefit of delivering a gas via a pressure mode as well as also a volume mode. So in scenarios where pressure could be advantageous than volume in certain situations. So we have the new ventilators are all computerized to use a common. The trigger, of course, will be by the ventilator, which is sensing that, okay, the flow has dropped, and so the trigger starts, the breath starts, or the negative pressure. And usually the negative pressure is only a 0.5 centimeter water pressure, which will trigger the breath.
Oh, there's a,
Somebody, are we okay? Yeah, okay. I have a few scenarios now which we'll talk about, which we experience in the neuro ICU, and this could be non-neuro or otherwise too, but the management of scenarios like these is a little different in the neuro patient. Okay. One of these scenarios is the acute respiratory distress syndrome. Okay. The definition of this is of a progressive or acutely injured, lung injured patient, where these criteria is there could be mild versus hypoxia developing, and where the PaO2 FiO2 ratio drops to 201 over 300. That's mild to moderate to severe. That means you cannot oxygenate the patient and is progressively. Findings in these cases are bilateral opacities. And of course, you have to make sure the condition cannot be explained by any other cause like cardiac failure or fluid overload, etc. So ARDS progresses very rapidly and has to be taken care of. Otherwise, it could be fatal if not supported by mechanical ventilation. A lot of the neurological events may lead to it, okay, like trauma of the head and spine, subarachnoid hemorrhages, even acute stroke, and like aspiration, pneumonias, etc., can lead to progression or starting of ARDS. Now, considerations in the neuro ICU or a neurological patient is, of course, one is to sedation is very important, and the patient has to not have dyssynchrony with the ventilator. Paralytics can be used in mild, moderate to severe ARDS if there is asynchrony, if the patient is fighting against the ventilator and not allowing it to breathe. So the patient needs to be, though it causes problems with neuro assessment at times, but we need to get the lungs better and oxygenation improved. There is equivocal data on mortality benefit in some of these scenarios by using these drugs, but of course it does improve, and let the lungs improve. If the lungs don't improve, the patient will progress to bad mortality will happen. Neuromonitoring should be conducted throughout this and closely, whatever we can. Use of steroids is equivocal, but if need to be used in some cases, over time and over the years, this has come and gone, and it should be initiated much early on. Of course, one has to be very careful that blood sugars will be raised, and they again cause more injury to the brain. So controlling hyperglycemia in these scenarios is very important. And fluid management is important. You have to monitor patient CVP, and especially if a patient is subarachnoid hemorrhage, you have to give often volume overload to sustain the blood pressure, especially after a post-clipping or post-repair of a aneurysm, and maintain a certain flow to the brain. In these cases, one has to be very careful that if we drop down the volume production, volume in the, excuse me, will lead to more ischemic injury to the brain. So vasoactive agents, again, could be instituted to maintain a certain amount of blood pressure in these cases. Often in non-neuro patients, we will use APRV methods for ventilator support in ARDS. We recommend that you don't use that because of the extreme high PEEP. That causes further intracranial elevation of intracranial pressure in these cases. So. The next is ARDS and consideration. Neuro is critical care. Low tidal volume and permissive hypercapnia. If one has to do so, one has to be very cautious because permissive hypercapnia will lead to further brain rise in intracranial pressure. Now, mostly these are lung protective mechanisms when ARDS, which we use, but one has to be careful. Again, the settings are satisfactory in a non-neuro injured patient where the PEEP could be, we can take the PEEP up to 20 or so, but in neuro injured patients, a high PEEP over 15 will not be well tolerated by the brain. And again, oxygen saturation, not 88 or 55 PaO2, we'd prefer to keep it over 60. Prone positioning could be done, but it's difficult many a times because you are keeping the patient's head end elevated at 30 centimeter water pressure, 30 degrees, and this angle may not be possible at times, but it still could be done. And as with the advent of the pandemic, we have seen prone positioning has helped significantly in cases of ARDS. ECMO, very difficult to use and would not be recommended, especially if there is a history, if the patient has had intracranial hemorrhage, and as you are going to use a high dose of anticoagulation, it will cause more problems and more bleeding. Inhaled nitric oxide has not really proven to change any morbidity or mortality. The other condition which may present to you in a neuro-injured patient is acute exacerbation of asthma or COPD. And asthma is an inflammatory disease process of the lungs, which is allergen mediated, and it's usually reversible airflow with bronchus, while COPD is a chronic injured lung from inflammatory process, as well as there is destruction of alveoli and also of the small airway with fibrosis, and as well as also has vascular destruction. Treatment, a little bit variation in both of them. In asthma, the treatment is inhaled beta agonist and also anticholinergics combined, as well as also systemic glucocorticosteroids, as well as antibiotics may be used if there is an infection. Otherwise, you should be using them. Magnesium acutely used to reduce smooth muscle spasm is helpful, while in COPD, antibiotics definitely help more than they do in asthma, and of course, the rest of the treatment is very similar. Uh, about 30 to 40% of the time in the progression of COPD, we have seen that non-invasive ventilatory support like a bilevel and also lately using a high flow nasal cannula will be able to help the patient and recover and avoid intubation. It's a high flow nasal cannula is much more tolerated than non-invasive ventilation. Indications of intubation in these cases will be when there is slowing of the respiratory rate, inability to maintain the respiratory effort, and sensorium is depressed and worsening hypercapnia and also respiratory acidosis that in spite of the non-invasive process, it hasn't been successful. This is often seen with an acute event in the brain which has taken place. This is a scenario of neurogenic pulmonary edema. This is of a 27-year-old female who presently presents with the acute subarachnoid hemorrhage due to a ruptured MCA aneurysm. An exam is lethargic with left hemiplegia. Blood pressure is 164/98 and is tachycardic, and also respiratory rate is rapid with oxygen 94% hypoxic on non-rebreathing mask. She is intubated and is arrival with, and CT and chest x-rays are shown. You can see there is pulmonary edema, and of course the CT of the head shows subarachnoid hemorrhage. This is a pulmonary edema not due to a cardiac event, but it's because of a neurological event. There's a massive catecholamine surge, which leads to elevation of acute pressures and leading to alveolar capillary leak. Criteria to diagnose these is non-cardiogenic and occurs rapidly at the onset of a neurological injury. And the good part is it's temporary. It resolves very quickly with help. And often you may see only part of the lung being affected rather than both. But commonly we see mostly bilateral both lungs. Treatment, of course, the patient needs support in the initial phase and oxygenation and PEEP they are responsive to PEEP positive end expiratory pressure, may need some diuresis to resolve, usually resolves very quickly, and the patient can come off the ventilator support. Another scenario is a spinal cord injury. This is a 28-year-old male who dove into a lake and became paraplegic by injury. You can see the fracture of the spine and displacement right at the sixth and seventh C-spine. He's intubated on arrival. He was given CPR, and exam shows that he does follow commands but he's quadriplegic. And on day 3, he's on pressure regulated ventilator support with PEEP of 12, 80% oxygen. His peak pressures are high at about 40. So our goal is in ventilator support, one thing very important is that the peak pressures are in this case, which is a pressure regulated volume, so the peak and the plateau pressures are the same. And to maintain and try to keep the pressures, peak and plateau pressures combined, if it is the plateau pressure to be below 32 or so. Otherwise, further lung injury is going to be expected to be seen in these patients and will progress to a situation of ARDS. Lung protective mechanisms or processes could be applied in this case. This is the last one. I'm going to talk about a little bit of pulmonary embolism. And the incidence in neurocritical care is really not known, but we do know that in paraplegic or quadriplegic, by the end of 12 months, about 80+% of the patient will have some form of DVT would have occurred. The incidence ranges in overall is about 35.7%, and for DVT and pulmonary embolism is 17.1% at 1 week of all neuro patients approximately. Of course, the biggest question comes that how do we protect that from happening, and what is the prophylaxis used? Most prophylaxis, like using, of course, compression stockings and all, could be somewhat helpful, but chemical prophylaxis, the number one. Of course, you can't use it all the time because of a recent intracranial hemorrhage or bleed, so one has to be very careful about that. Usual treatment is anticoagulants, thrombolytics, unfortunately, in most of these cases, unless the patient, of course, has had an ischemic stroke and has already received a thrombolysis and has simultaneously had a PE. So in that case, it's different. IVC filters, if contraindication for anticoagulation. But we do have a better, newer techniques and technology in these cases is mechanical clot retractions, which could be done. And at PBHMC, this technology is available, and there are a lot of physicians who are trained in doing that. This could be life-saving in our times. In summary, the takeaway is respiratory support in neurocritical patients requires a little different management in general critical care. Oxygen requirements of PEEP applications are a little bit different, especially in ARDS, and the management of pulmonary embolism, and of course the management of ARDS. Thank you.
Thank you, Dr. Sadana.
Okay.
Very good. Any questions for Dr. Sadana? You can put it in the chat.